and the brain begins to develop differently. So those are those roots in place from that attachment trauma that then when other negative experiences happen in life, it can set off an eating disorder because those seeds have been planted.
And there she is. Oh.
That was fun.
That was fun. Mommy enjoyed that. I enjoyed that. You were right behind the curtains. That's where you were. Well, hi, Marnie. Thank you so much for being part of our third annual Innovative Child Therapy Symposium. I just met you years ago through EMDR community in Orlando, Florida. I fell in love with your work. I've reached out to you several times for consultation, and it has been amazing. And I remember something that you told me during my first consultation session with you was about the importance of the team approach when working with children and teens that are experiencing eating disorders. So that's what I would love to cover in our conversation today here. But before we do that, let me have you just introduce yourself, tell people who you are and what you do.
My name is Marnie Davis. I'm a licensed mental health counselor, certified eating disorder specialist and supervisor, which means I supervise folks who are interested in being certified eating disorder specialists like myself. And then I'm also a certified EMDR therapist and EMDR improved consultant. I have been a past president of our local IADEP chapter, the Central Florida IADEP chapter, and I'm held various positions, but I am now currently and have been for many years the co-CE chair for the IADEP chapter. I'm also an Orlando affiliate, which means that I'm a volunteer for the beautiful, amazing organization called the National Alliance for Eating Disorders Awareness. Actually, it's the National Alliance for Eating Disorders now. They've changed their name. Sorry, I included part of their old name. And I'm very honored to be a volunteer because they really provide those extra support services, those wraparound services, all those extra aspects of care that we need in the field of eating disorders. So that was a little tidbit about me to not talk too long about myself.
You are amazing. You have so many qualifications, so much going on. And I know you have a big heart. I know when I've reached out to you for consultation, it's been out of just really needing to talk to an expert in the area, and that you are with just lots of resources. Like you shared with me some ideas regarding EMDR and different assessments and everything. So thank you so much.
You're welcome. I think naturally just what comes with me is kindness. And I think that that's something that I encourage. It comes in as a therapeutic intervention. There's a sweet little doggy offering you kindness. And I think that just kind, gentle approach really helps our clients shift into that kind, gentle approach to themselves and that curious approach to what's going on inside of them and why did the eating disorder or whatever other firefighter, as I call it, has come out. Why is that there? And I do use an integrated approach. Obviously, I'm an EMDR therapist through and through, and I use that conceptualization, but I'm also a strength-based therapist. I use DBT, CBT, acceptance and commitment therapy, all of those lovely modalities all packed into one. But EMDR is my primary focus.
It sounds like with the mention of firefighter, there might be some IFS in there too.
Yes, there is.
All of different acronyms. Let's just name them or describe them for those that may not be familiar. EMDR is eye movement desensitization reprocessing. IFS is internal family systems. There's a lot of them, isn't there? DBT, dialectical behavior therapy, and ACT, acceptance and commitment therapy. Such
Yeah.
good stuff. And when you talk about kindness, it seems like you're really speaking about the importance of cues of safety and connection. And I'm with you. And you
Yeah.
have that through and through. I
Yeah.
found it as a consultant. I can only imagine what it's like to be your client.
Yeah. And really looking at those parts through that lens, right? Eating disorder work naturally takes us to parts work because we've always externalized this eating disorder part. And it's really looking at it. Yeah, the eating disorder has caused destruction and tragedy and chaos and pain. And yet it didn't just come because it didn't have anything better to do. It came about in the system and grabbed onto this nonsense that our world is consumed with regarding fat phobia, anti-fatness, thin ideal, weight loss, all of that. And it grabs onto it, but it really wasn't meant to try to cause destruction. It was just there to put out a fire. That affect dysregulation that occurs with trauma and negative life experiences and disconnection. So it's really kind of looking at these parts with loving, gentle eyes and seeing how we can assist them, how we can assist the ones that are more wounded, those ones with burdens. There's IFS for you, and helping those protectors learn to do different things that actually promote quality of life while managing the distress in the system.
So good, so good. And I think about one of your ideas was for me was to use the fill-in state protocol in EMDR,
Yes.
and I think that really speaks to it's striving to serve a purpose, even though it's very dangerous and there's lots of concerns with it. We need to underneath what purpose is it trying to serve?
Yeah, yeah. So while we're creating safety, which we're going to talk about in the comprehensive team approach, my job as a therapist is to look at those deficits. What are the deficits that are happening? We're talking about kids and those kiddos' lives that have left this feeling state of power, or the buzzword that's often used with eating disorders, control, which actually means control of many, many, many different things. We have to be careful to not just go with control, but what is the specifics of control? But so it creates all these really powerful feeling states that get attached to restricting, or the idea of this is mine, you can't touch this, might get connected to binging and purging. A sense of comfort and being cared for and taken care of might come through a behavior. And so if we can look at it curiously, we can look at what resources, right? Our folks with negative life experiences and disconnection are under-resourced. Those adaptive networks in the brain need us to blow on them and fan the flame on them. So we're filling in those gaps by matching, all right, if they're feeling power by using this behavior, let's build up their ability to feel power in different ways. And then we can separate out that feeling state from that behavior and then find out where the deficit is. What's the negative belief about oneself? What are the negative experiences that cause that little kiddo to feel powerless or to feel not seen or to feel ... So it really is this collaborative, curious, kind, respectful, right? We respect what the disorder's doing while honoring that it's causing chaos and pain at the same time. So we're going to wrap them in care. And this is where I can step right into talking about comprehensive care. When we work with eating disorders, we want to make sure, first of all, that we have the skill set. It is a specialized disorder and piece of work within clients. And that's because it affects lots of our systems. We're going to want to be, it has a neurobiological basis. It has a psychological basis. It has socio and cultural. It has the genetic. It has the familial, and it also has the trauma-based focus. So we're going to really want to be all these different pieces that come in together to make this perfect storm. It's connected with the child's temperament, why one child in a house may have a similar upbringing and yet have the roots being developed for the development of an eating disorder. They have found that 70 to 100% of eating disorders are rooted in attachment, right? Those early life experiences that set up our affect management, our ability to manage the distress that comes inside, and also separate ourselves from the world. And with attachment injuries, food gets mixed up, body gets mixed up, the separation between myself and others gets mixed up. And that ability to regulate and that ability to know that you're taken care of and that co-regulation gets all mixed up, and the brain begins to develop differently. So those are those roots in place from that attachment trauma that then when other negative experiences happen in life, it can set off an eating disorder because those seeds have been planted.
Oh,
So
wow.
yeah.
That's a good, it's kind of blowing my mind thinking about like an infant, how they, how they nurse, is also a source of comfort and connection. So it's so intertwined.
Yes, so intertwined how their emotion regulation with food and body is all intermixed in those early years. Even when parents are doing the absolute best they can, right? It doesn't mean that parents have done things wrong because there's attachment injuries. It just means we need to be looking at them and curious about them and bringing the family comprehensive treatment into the care. We're not blaming the family. We're just saying this is a disease that develops often within a family, especially when we're looking at younger kiddos. So how can we support the family? How can we support the family in change, in being curious about their own ways of being and looking at the dynamic? So we're going to include in family therapy. We're going to be including in parent education. With younger kiddos, we are going to be looking at something that I won't spend a lot of time on because it could be hours of presentation on family-based therapy. So family-based therapy is really allowing the family to be the place of creating the constant, creating the boundaries with food and with nourishment. So it is a stage model, a 3-stage model, where the child is slowly developing more autonomy, but it's kind of taking the treatment center idea and putting it in the home rather than taking the child out of the home, which is not what we would want to be doing. So with younger kids, we are looking at family-based model. As kids get older, we are moving a little bit more away from that model and relying more on the team approach. Which
okay, so like with the little ones, you want to keep them in the family. Is that because of the roots and attachment? You want to develop the relationships deep? Okay.
Yeah. And so the dietitian is going to be working within the family. The dietitian might be coming in and noticing and watching what's going on around the dinner table and supporting, but it really is put into the hands of the parents to create the structure and recognizing the boundaries and reinforcement, and really almost like doing Control-Alt-Delete on the child's brain with how food and body and weight has gotten skewed, bringing it back to food being what it is. Food is nourishing up, food is giving us strength, food is creating connection around the table, food is joining, really allowing food to go back in its place within the family unit.
Oh, that's so good. So I'm picturing a young child versus an adolescent in the home for the young child, but the team would be more kind of integrated into the family day to day. But the adolescent may go to a treatment center, and that place that would all be in place there. But then the family may come to the treatment center, whether virtually or person.
Yeah, we're still doing family work even as the child is a little bit older. It just looks different. It's not quite as much ingrained in the family unit at home. It might be bringing the teenager to treatment, having the family come and do family therapy at the treatment center, whether that be outpatient, intensive outpatient, partial hospitalization, residential or inpatient. And then we'll be doing continued family work in the outpatient world. So what we're seeing is we're beginning to create these wraparound services. We want to make sure that there's a therapist and a dietitian on board. We want to make sure that someone is looking at everything other than the food while including the food. And then someone who's really focused on breaking down the maladaptive narrative that's created from society, breaking down all the good and bad, right or wrong with food, that food is moral or that food is black and white. Food isn't in any of those categories, pulling us out of diet mentality. helping us move out of this idea that fat is bad and a higher weight is bad, and really looking at nourishing ourselves abundantly, nourishing ourselves to the place to let ourselves live our values, live our joys, introducing us to words like joyful movement, because even little kids, they're learning about, I need to burn calories, right? There's a statistic that the National Alliance posts that's 40 to 60% of elementary school females, because a lot of research has still been on those who identify as female, are concerned about their weight or becoming fat.
Oh, 46%.
Yes. And they found pretty similar statistics of those that have already learned to throw up to lose weight at that age. And what we've seen during the pandemic is an influx of that age individuals that are dealing with eating disorders. Their lives have been turned upside down. There has been chronic disconnection, isolation, depression, anxiety, and they're on all of this social media that is feeding this idea of control your body, control your weight, fix this, fix that. So I'm inundated with calls of 14, 15, 16-year-old kids that I've never been called, had that many calls coming in from that age group. Mm-hmm. So really looking at having this therapist and the dietitian to do this work together. Sometimes us dietitians have to do some of the nutrition work. So it's really important for me to know that stuff, because financially, just some people's resistance or hesitation or uncertainty about the process, they may not get with that dietitian right away. So I need to be able to do a little bit of patchwork while they're getting placed with a dietitian. And then we want to make sure we have a primary care physician. Remember, an eating disorder is using behaviors, the maladaptive coping skills that affect them physically. One individual dies every 52 minutes. It's from an eating disorder. And others suffer lifelong health issues because of eating disorder behaviors. So we want to be making sure a PCP who is eating disorder informed, because not all of them are, nothing against PCPs that aren't, they don't learn much of it in their med school from what I've learned.
The primary care physician, their doctor in essence, right?
Yeah. So it's really looking at what primary care physicians have are either willing to learn about it or have done a little bit extra learning, and making sure that individual, that kiddo, is seeing a doctor who is not going to reinforce weight stigma. If a young kid in a higher weight body walks into that office, we don't want that child shamed. We don't want that to be suddenly all about that weight and that the kid needs to lose weight and that'll fix the problem. We want it to be a kind, caring, loving environment that's going to look at that child holistically, to know what blood work to do, and to know that that kiddo walking in a larger size body might be restricting more than they're doing anything else. And it's sometimes assumed, that kid must be overeating. So it's really having these wise, informed providers that work closely with me and the dietitian. And then depending on the age of the kid and depending on what's going on, we're going to bring in the psychiatric component. We want to be looking at, is there a need on a brain-based space for medication? And I tell some of my families, it's just training wheels sometimes. We're going to respect parents' beliefs about not wanting their kids on medication early on. I understand that in brain development. And as we go, we're going to be looking at, is it needed at some point? Some brains need a little bit of help, right? So
it's scary for some parents that thought of medication, but getting a psychiatrist on board that specializes in that, I think is, it's looking at that area of need, and then they can make the decision at that time.
It's like, let's get all the information out, and now the parents can make the best decision from what they've heard from all the professionals. So that's kind of the core four. But then we also want to be looking at family therapy. We might be looking at doing some kind of we want to be assessing for higher level of care, even though we wouldn't want to take kiddos out of the home. We do need to be always assessing of, do we have enough care for this child? Is this an okay environment? Is there a need for something more than this? So we're doing that all along. And then we might be, depending on the age of the kid, adding in a DBT group a kid's
Mm,
DBT group to really enhance their emotion regulation, to enhance their mindfulness skills, address interpersonal and communication skills. We might have that kid step into a dance class that is maybe trauma informed or eating disorder informed, a
mm,
place where they could learn to move their body in the way that they enjoyed. So we're really looking at wrapping the individual in care. And then there are some adolescent support groups. So a place for an adolescent or a child to go to where others are talking and thinking the same way they are. Because the trouble is the kiddo goes back to school and the talk at school is about, again, this kind of blows your mind in elementary school, but the talk is about dieting and body and weight and good food, bad food, what I'm not supposed to have, what I can have. So to have an environment where they can go and be with other teens, with other kids that are looking at accepting their body, loving their body,
mm.
respecting their body, caretaking their body, whatever words they align with, can be a really empowering situation for them or experience for them.
It seems like what I hear you saying, the most important thing is to have adequate training and then make
Yeah.
sure you don't work in isolation and
Yeah.
then resource these kids so they have a lot of not only skills but connections. I go back to like years ago, I had the basic EMDR training with Linda Ruff, and she said, you need way more good stuff than tough stuff.
Yeah.
And that's like the best piece of advice. Build up the resources while you're working on the tough stuff.
Yeah,
But
and
having
just
that
as you
support.
said, we're building it like internally, all those resources, right? And then we're building out those external resources. So when we're listening to these kids, we're listening for all the negative, but just like you said, because Linda Ruff's my trainer and my dear
Her.
mentor too, that we want to be looking for all that positive. Who's the person in your life that makes you feel comfortable, that makes you feel seen, that makes you light up? Who is that person in your life, as small of a role as they may have? So we're bringing in and looking and resourcing, just like you said, both internally and wrapping them in a community that can love and support and foster their growth, their strengths, their resilience, their beauty, just as they are. Yeah.
Oh, I love it. I love it. I love it. One thing that I noticed about you when I spoke with you in consultation is you're very familiar with the physicians in the area, with the dietitians in your area. It seems like you have a collaborative, just a collective knowledge and maybe share the same clientele. So how would someone do that in their community if they were just getting trained? How do you connect with other people? Are there events or do you create them or how does that look?
Well, yes. Well, locally, we have our local IADAP chapter, which is the International Association of Eating Disorder Professionals.
Okay.
Back before COVID, it was really nice because when we'd have our quarterly meetings, we'd always invite in a great speaker and we'd have networking. It was a chance to talk and meet and give your cards out and pass your name along. So we don't have those quite as much now, but on our virtual format, we do as much networking as we can. And then really it's about, you have a client come in, so you match them up with a dietitian. You now have a chance to form a relationship with that dietitian, calling up that dietitian, consulting on that client, asking more questions about that dietitian. Just again, and I know it's really hard to get in touch with doctors, but some of them are actually really loving and open and give me their cell phone and let me know, as long as I don't abuse it, that I'm allowed to reach out to them and speak to them. So it might be picking up the phone and calling me and saying, hey, Marnie, who do you network with? Who are your circle of providers?
Mm-hmm.
Could I have their names? There's also a really great referral from the National Alliance for Eating Disorders, which is called Find ED Help.
Okay.
And it is a search engine for not only providers, but treatment centers. So all the treatment providers that are listed in there, which include doctors, dietitians, therapists, and many others, they have all been vetted by the Alliance, which means they have checked into them, make sure that they do have some extra education and expertise, and you can utilize that. And then again, pick up the phone. I know we're all really busy, but I love it when you called me, Jackie. I love it when somebody reaches out and wants to talk and staff cases or just ask what I do or if I could give them some referrals. So really just using the people that you know and reaching out and just striking up a conversation.
Oh
Yeah.
my goodness, I love it. Well, it was interesting. Like I know your knowledge base, and I've learned so much from you and reached out to you before. But it wasn't until we connected. I haven't talked to you in over a year now, and connected through this call. I heard your voice, and immediately it took me to that space of gratitude from the last time when I called you, and I was so desperate for information. So I love the fact that even amongst us, like helping professionals, we're forming relationships that makes us better able to help our clients.
Yeah, so we're always consulting, right? I think you as someone who,
Okay, so she's going to join us for this.
that's okay. Hello, sweetheart. She had a few things to say.
She does. So you could just start back with
Just what you were saying that no, I think of you as this gifted, skilled clinician that knows it all. And yet you reached out to consult on a case that wasn't in your central area of skill set. And I think that's so important. I reach out even on eating disorder cases to my colleague. You know what? Let me just run this by you. What do you think? So if you're someone new, if you're someone who's a veteran in this field, even when you feel skilled at it, to reach out and consult, ask those questions so that you can grow and learn, and you can know, you know what, maybe it's best I refer this client out. It's okay to refer out.
Oh, I
Right?
love it. And we're not working in isolation either. So
No.
oh, that's fantastic. Well, thank you so much, Marnie. I want to make sure people know where to go to either get trained or to learn more from you or whatever you have to offer. If you could just mention some websites, and then I'll link them below this video as well.
Yeah, sure. Well, my website, you can always check me out there, is marniedavislmhc.com. But you also can go to the Central Florida IADEP and just type that in. I'm trying to think of exactly what it looks like when we type it into the search screen, but the Central Florida IADEP chapter, you can find that for upcoming local trainings. I will mention that the National Alliance for Eating Disorders has lots of training days, lots of presentations for all different levels on all different topics. That's a great resource to find training. And then Linda Ruff, who we mentioned, her and I have started a training platform called Elevate EMDR, and it has my engaging in the dance, eating disorders, EMDR, and ego states, engaging in the dance, which is a 4.5-hour EMDR training program. And then we are going to be putting up on there the training I just did this past Friday for a bunch of folks on treating eating disorders and the trauma that lies beneath, the curious and informed approach. So that's for non-EMDR therapists that want to understand more about treating eating disorders with the trauma lens. And what it'll do, I think, is spark a lot of people to possibly get EMDR trained, because there's lots of little tidbits that connect with EMDR. So that's a few places to find me, and I can always share all the treatment centers. Renfrew, Center for Discovery, a lot of them offer different CE events along the way, so people can just reach out to them, get on their listservs, and then they can be aware of when free or low cost. And then I do need to mention the IADEP Symposium. The symposium is happening at the end of March. Okay. It was supposed to be at the Champions Gate, but they just canceled it this past the in-person format and made it virtual. So people can access it and learn from all the greats that I have learned from. So many great presentations on working with individuals of all ages, different race, ethnicity. Sorry, my tongue's a little tied. Sexual orientation across genders. There's a broad view of all different kinds of programming at the symposium. And I think it's around like March 23rd, 24th.
Okay. We'll put the link down below this video for that. Is it virtual or in person?
Yes, it is. That's what as my tongue was tied. It was supposed to be in person, but because of the Omicron variant and all that it's done to us, they decided just this past Thursday or Friday to make it virtual. Okay. So and they usually have it up for like 3 or 4 months so that we have time to watch all the great programs.
Okay. Oh, this has been wonderful. Thank you so much, Marnie.
You
All
are
right.
so welcome. Thank you so much for asking me to join you. I so appreciate you and all the work that you do, Jackie. Thank you so
Thank
much.
you. Bye-bye.
All right, bye-bye.
And there she is.